my head to toe assessment for nursing 6511. My name is Susannah Adegbenjo. I'm a nurse practitioner student at Winston-Salem State University. And this is John that is helping me out with my assessment today. How are you today?
I'm doing quite well. How are you?
Okay, before I start my assessment, I'm gonna go ahead and wash my hands. So for my head to toe assessment, I'm gonna start with the hair, nail, and skin. With the skin, I'm going to inspect the skin. I will look at the color, the texture. I will look at if there is any lesion, rashes, and I will also look at the tugger, pick it up. This is to make sure he is not dehydrated. I will look at the tugger. I will look at the contour of the skin as well. So for the nails, I will look at how the nail is attached to the nail beds. I will check the capillary refills, make sure they pink out when I release my hand, and I will check for clubbing. Can you do this for me, John? And I'm checking the angle of the nail, and he does have good angle, so he has no clubbing going on. So after I check the nail, I'm gonna check the hair because it's part of the integumentary system. I'm looking at the hair, I'm looking at the hair distribution. I'm looking at if there is any meats or lice. I will part the hair and look at the texture. Okay, so after I do that, now I'm gonna go to the head and neck assessment or examination. I will look at the scalp. I will start with the head, look at the scalp. I will look at the skull to make sure there is no indentation or any soft spots. After I look at the skull, I will look at the face. I will look at the symmetry of the face and make sure the face is symmetrical. While I'm doing that, I'm checking for the cranial nerve 5, which is the trigeminal. Can you smile for me, John? And can you clench your teeth and close your eyes? Don't let me open it, okay? And I'm also checking the facial nerves at the same time. So I'm gonna check the temporomandibular joint. Okay. Can you, okay, open your mouth? Okay, I can feel that under my tongue, my fingers, so, yeah. Okay, I'm not feeling any crepitus, I'm not feeling any crackling sound to say there is a dislocation there. So, so after that, I'm gonna move on to, you're gonna also puff your cheeks, and it's strong. So, so that concludes the facial nerves. So I'm gonna move on to the ear. When we make sure the ear is symmetrical on both sides, and there is well aligned with the eye. I will look at the lobes, ear lobes, and look at the back of it to make sure there is no rashes, no soreness there. then I will look with my otoscope. Great. Okay. So I'm looking at the ear canal. There is no effusion, no fluid. And then a little further, I will see the tympanic membrane. There is no break. There is no tear in the tympanic membrane, and it is gray in color, like grayish color, as it's supposed to be. And I'm also supposed to do the same on the other side. So after looking at the ear, I will look at the nose. The nose is in the center, and is Y base is symmetrical. I will look in the nose. I will look inside the nose. Is pink. There is no drainage or discharges from the nose. The septum is midline. There is no defect, and I will look on the other side as well. Is pink. No drainage. And the septum is midline. So now I'm going to look at the eyes. With the eyes, I will see how the eyelid is covering the sclera of the eye. I'm looking at the conjunctiva. It is supposed to be white. I'm looking at the eyelid is supposed to cover halfway of the sclera. I'm looking at the eyebrow and eyelashes. They are well aligned. Then I'm going to look inside. I will just look from afar, just to check the reflexes. And then the red reflex. Yeah, the red reflex. And inside, I would look at the more fovea, macular, the vessels in there, the vessels, arteries, and veins. They are usually 2 to 1, and there I will make sure I will see if there is any exudate or papilledema inside there. So that concludes the examination of the eye. So I'm going to go on to the mouth. I'm looking at the mouth. I'm looking at the lips. Make sure I will see if the lips are dry or cracked. Then I will look at open your mouth for me. I will look at the tongue, the teeth. I will make sure if there are any loose tooth. I will look to see if there is the buccal mucosa, to make sure it's clean, the base of the tongue. And then I will look on top of the tongue. It's supposed to be dry. Stick your tongue out for me and go ha. Okay, The uvula is midline. The uvula is midline, and I'm going to, oh, I forgot to get a tongue blade. And I'm gonna check cranial nerve 9 and 10 to just go, okay. And I will trigger that in the back of the throat. I'm looking at the pharynx as well, and soft palate and hard palate. Okay, that concludes the examination of the mouth. So meanwhile, I'm going to palpate with my fingers, tip of my fingers. I'm going to palpate for the, first of all, I'm going to palpate for the sinuses, the frontal sinus, and then the maxillary sinus. And normally, they should not be palpable. Then I'm going to check the lymph nodes, the pre-auricular lymph nodes, posterior auricular lymph nodes, occipital lymph nodes, submandibular, submental lymph nodes, tonsillar lymph node. Then I'm gonna look at the neck, make sure the neck is symmetrical, is midline. I'm gonna try to palpate for the, let me come on this side. I'm gonna try to palpate for the cricoid process, cricoid cartilage, and then try to swallow for me, John. Okay, and then that will give me the landmark for the thyroid, and I'm gonna palpate the thyroid for any kind of tenderness or nodules. Okay, so now I'm gonna look for the deep on both sides, the posterior cervical lymph nodes, anterior lymph nodes, subclavicular, supraclavicular lymph nodes, axillary, deep axillary lymph nodes, axillary lymph nodes, trochlear lymph nodes, and femoral, when you lay down, when you, I will check the femoral lymph nodes as well. So after the palpation for the lymph nodes, then I'm gonna go ahead and check the chest for the respiratory system for John. I will first of all look and observe how he breathes, the rate, the rhythm, and if he's using his accessory muscles to breathe, those will be visible around the clavicular area if he's using the accessory muscles to breathe. And also I can tell if he's using the accessory muscles from the abdomen, if he's using it to breathe. I'm gonna check the rate, the rhythm, the depth of his breathing. Then I'm gonna observe the anterior posterior diameter, compare it to the lateral diameter to make sure they are usually at a ratio of 1 to 2. So after that, I'm going to percuss. And I'm percussing for the intercostal space, and it's usually resonant. Okay, I'm gonna do the same in the back. I'm gonna palpate to make sure there is no crepitus. You feel any pain, John, with this? Any pain? If there is any clavicular fracture or rib fracture, it's going to, any pain? No pain, no crepitus? Okay. I'm gonna also palpate for the tactile fremitus. So you will say 99. 99?
99.
And I'm using the vibration in my hand, ulnar side of my hands to feel that. Okay, go ahead.
99.
Okay.
99.
Okay.
99. 99.
Okay. And I'll do the same in the front. Okay.
99. 99. 99. 99.
Okay. So that's tactile fremitus. So if there is any consolidation, the vibration will not come through to my hand that much. So now I'm going to check the lungs. Auscultate the lungs in some areas. Breathing. Okay. Okay. On this side. Okay. And I'll do the same in the back. Okay, so just breathe in. Mm-hmm. Mm-hmm. Okay. I'm going to listen at the trachea spot. Okay, the air movement. And also, I'm going to palpate for the carotid of the neck. And with my bell, I'm going to listen to the bruit if there is any of the carotid artery. Okay, none. And I'll do the same on this side. Okay. So now I'm gonna ask you to lay down so I can do your heart exam. So meanwhile, I'm looking from the right side. Turn your head this way. Just turn your head. The bed is supposed to be at 30-degree angle. Bring your head up some. Okay. 30-degree angle. So I will look at this is your super sternal notch, your sternocleidomastoid, suprasternal notch. Okay, so I'm looking. So I'm gonna measure the JVD. About 3 centimeters, so which is good. Okay, and then after that, I'm gonna just first of all, I'm gonna palpate to see this is your clavicle at this level of the second and third intercostal space along the sternum here at level of the second and third interthoracic. That is on the left side. That is the pulmonic side. And I'm gonna first of all palpate them, and second and third intercostal space on the right is the aortic side. Then second and third, fourth, that's the sternum. I'm gonna palpate at the nipple line, which will be around the 5th intercostal space, mid-clavicular. That would be the point of maximum impulse, and that would be my mitral space. And then the third, fourth, and fifth would be my tricuspid space. So now I'm gonna go back and auscultate with my bell and my diaphragm. First, at the level of my point of maximum impulse, I'm auscultating with my bell. Okay, and then the tricuspid space, I'm auscultating also with my bell. Pulmonic. And aortic with my bell. Then I'm gonna go ahead and auscultate with my diaphragm as well. So, I'm gonna now move on. I'm gonna move on and check the abdomen. For the abdominal, I will have your hand on your side. And first of all, I'm gonna look at the contour of the abdomen. I'm gonna look at the skin color, if there is any pulsation, or if I can notice any like bowel movements through the abdomen. And if I have to, I'm gonna look at it from an angle so that I can see everything better. If there is any pulsation, if there is any bowel movement that I can see. Then after the observation, now I'm going to palpate. No, before I palpate, I'm going to listen to with my bell to the aorta. So this is the sternum, Seifert process. So I'm listening to my aorta for bruit. Then, where is your belly button? Right there. Okay. So, midway there on the right, I'm going to listen to the right renal artery and the left renal artery. And then the iliac artery. And then the femoral artery. Meanwhile, I'm listening with my bell for brewing. So then I'm going to listen to the bowel sounds in the 4 quadrants. And I have to listen for at least 2 minutes. If I'm not hearing it fast enough, I can listen up to 5 minutes for the bowel sounds. So after auscultating that, then I'm going to percuss. And I'm going to percuss for the liver space. Let's see here. Mid-clavicular line, intercostal space. And when I reach dullness, okay, and then from the umbilicus, tympani, until I reach the dullness. And then I will measure the space, and it's usually 6 to 8 centimeters. Then on the left, I'm going to percuss for the spleen, mid-clavicular line, intercostal space. I want you to breathe in and hold it. Okay, release. So while I'm percussing for the spleen, if I hear any dullness here, it should be timpani like I'm doing it. But if there is dullness, that means the spleen is exposed and it could indicate splenomegaly. But meanwhile, when I was percussing, it was all lung space, resonant. Okay. So I check. I think, oh, now you can sit back up. While I was doing the ear exam, I didn't remember to check for bone and air conduction. So I'm gonna go ahead and do that now. Can you hear it?
No, I
You can't? Can you
can't. No, I
hear it?
can't.
Okay. Air conduction should be 2 times the bone conduction, so you should hear it longer. And I will do it on the other side as well. Can you hear it?
No, I can't.
Okay. And then that is the Weber. Now we're gonna do the Renee. Which side are you hearing it?
This side.
Let's.
Well,
Which side?
I don't hear, I just feel it.
Oh yeah, but on which side?
Like this side.
So you should hear it on both sides. Let's see.
Yeah, I hear on both sides.
Yeah, it was not activated good enough. Okay, you should. So that means you can hear on both sides. Yeah, and that is checking your sensory nervous hearing. The other one is checking your conductive hearing. Okay. So, now we're gonna go on to the upper extremity examination. So the upper extremity examination, we're going to check, I'm gonna just look at the joints, shoulder joints. Acromion process of the scapula is joining to the humerus and the clavicle, and on both sides. And I'm also gonna look at the muscles. I'll look at the muscles there, acromion process, joining with the humerus and the clavicle. And the muscle, there is no muscle wasting, there is no atrophy, and there is no quickening of the muscles, felicitas. So anyway, now I'm gonna check the shoulder, movement, range of motion. So do you wanna stand up for this? Okay, so can you extend your, okay? Can you, yeah, that's, abduction, ADD adduction, yes. And then external rotation, and then internal rotation. Yeah. And any pain, any resistance while you do them, okay. And now we're gonna look at the elbow joints, the olecranon process, and make sure there is no deformity there, there's no swelling, there is no warmth, that everything is, the elbow joint is intact, there is no dislocation that I can see, external deformity that I can see. And now we're going to do the range of motion for the elbow. Can you flex, extend, and then ADD adduction, and then abduction, pronation, supination, okay? All right, now I'm going to check your hand and the wrist joints. I'm checking to make sure there is no fracture, no crepitus, any pain. I'm checking the joints. So I'm going to go on and check your wrist and your hand. From the metacarpal phalangeal joint, proximal phalangeal joint, and distal phalangeal joints, and metacarpal and the phalangeal joint for that one, for the thumb, and your wrist carpal joints reach. There is no, I'm checking them for swelling, redness, no bagginess, no lesion, no warmth, and do you feel any pain? And I'll do the same on this side too, and check that. And now we're going to go through the range of motion, flexion, extension, ABD abduction, and ADD adduction. And we're going to check for carpal tunnel. I'm going to use the Tinel test by tapping the medial nerve. Any pain, numbness, or anything, tingling? Okay. So no carpal tunnel. And now we're going to check for. I'm going to go to your lower extremity. Okay, you can lay down. I'm going to start with the hip. Anterior superior iliac spine, the dimple, and then posterior superior iliac spine. Those are the landmarks for the hip. Then I'm going to, this is the flexion. Okay, lay on your back and just bring your leg up. Okay, and I'm also checking that. Okay, flexion and flexion, extension, then abduction, adduction, internal rotation, external rotation. And I'm going to do a maneuver in case you have peritonitis or appendicitis, the psoas muscle in the abdomen. Do you feel any pain?
No, ma'am.
Okay. Any pain? Okay. So that's just checking for the for peritonitis with that. Also, let's see. Oh no, we're going to the knee. The knee. I'm checking the knee for effusion. This is the patella, and these are the joint. There is no effusion, and there is no bagginess, there is no swelling. Then we're going to make the knee go through the range of motion, the flexion, extension, ABD, abduction, and adduction. Okay. We're going to go to the foot and the ankle. I'm checking them right now. I'm palpating them. No bagginess, no swelling, no crepitus. Metatarsophalangeal joints here. I'm going to check them. Then the phalangeal joints on each toe, and then the calcaneus. There is no deformity and no swelling. So we're going to go through the range of motion, flexion, okay, extension, okay, ABD, abduction, and then adduction. Okay. So now that brings us to the cranial nerve. Olfactory cranial nerve. Cranial nerve 1 is the olfactory. We didn't do it that time because I know we're going to do it now. Abi?
Still paranoid.
So close your nose and can you smell this?
Coffee. Alcohol.
And breathe in and breathe out. Okay. The nose is patent, is not blocked, is not congested. Cranial nerve 2, you're going to read from the Snelling chart, and you just read the line that you can see.
L G F Q T R B C.
Okay, that is the 2020 line, so which means John can see at 20 feet what's normal people can see at 20 feet. The bigger the denominator, the worse the eyes are. That's optic nerve. Cranial nerve 2. Cranial nerve 3, 4, and 6 is going to check for the oculomotor, trigeminal, and abducent, and it's by confrontation. So just tell me when you can see
No.
my wiggle fingers. This is checking the
No.
peripheral vision.
No. 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 No.
If there is any problem with any of this, that if he's having problem to see, we're going to do the cover. Cover one side and you tell me.
No. No.
So this will tell us, cover the other one. This will tell us exactly where the problem is.
No.
Okay. Now we're going to do 6 cardinal gaze. You can see, just follow without moving your head, follow with your eyes. Okay. And I'm going to hold this and you look at the wall, and look at this pen light. Look at the wall. Look at the pen light. Okay. And he was able to make the transition very smoothly. The eyes was not shaking, no nystagmus. Okay. So we're going to also check cranial nerve 5, puff your cheek, that which is the trigeminal, puff your cheek, and
You should press this a little on the
puff your cheeks, close your eyes and don't let me open it. Wrinkle your forehead and smile. Clench your teeth, okay. And the cranial nerve 5 is they're intact, and facial nerves too are intact, which is cranial nerve 7. We're going to, we've already checked abducent. Now we're going to go to 8 with the Weber and Renee for hearing. Can you hear this? Tell me when you can't hear it anymore.
No,
Okay. And air conduction is longer than the bone conduction. Okay. And the Renee test is checking for the sensory hearing. Can you hear?
Mm-hmm.
Oh, okay. Which side?
Both sides.
Okay, good. So that's cranial nerve 8. 9 and 10 is for the gag reflex. Oh, what is this? The uvula is center, and I'm gonna just cause some gag. Okay, and glossopharyngeal for 9, and vagal for 10. And then we're gonna do a spinal accessory, which is cranial nerve 11, okay, and he was able to do that with, with my resistance. Cranial nerve 12 is the hypoglossal. Stick your tongue out and turn it, okay, yeah. He was able to move the tongue. Now we're going to go to deep tendon reflexes. Okay. Radial, brachial, biceps, triceps. Okay. And we do it on the other side as well. Patella, reflex. Okay. Did you just do it? And then Achilles. Okay. Okay. So those are the tendon reflexes. So now we're going to do the special test for sensory test, rapid alternating movement, and you increase that, and he was able to do it faster. And then if you lay down, we're going to do the point. This is for the lower extremity. You put your heel on your knee all the way to your toe, to your big toe. Okay. That, and you do it on the other side as well. Now you're going to sit down. I'm going to give you something. Okay, close your eyes. You're going to tell me what I gave you by feeling it.
Coin.
Okay, good. That will work. You don't have to tell me how much. Okay. Okay. This will conclude our head to toe assessment. Thank you, John, for coming out.
Thank you for having me.